hoping a few more folks show up. If not, we can have the really small group conversation about shock. That'll be shocking. How are we all doing? We're at like the midpoint in the semester. Are we hanging in there? We in a rhythm? Is stuff super weird? How are we feeling?
I mean, you know, it's life.
It's COVID life. Yeah.
Yeah. Strange.
Okay. So nothing like too out of the ordinary for you. It feels like you're busy with school and okay. And hey, if you can't hang out with people, you might as well hang out with books, right?
Yeah, keeping me busy, that's for sure. It's kind
Okay.
of nice to have like a moment to think and panic about, you know, the fall of mankind because I'm too busy.
There you go. You're like, if I can just think about more ways to die in pathophysiology class, I don't have to think about, yeah. Yep. Bella, you're doing good?
Nothing special's happening. Just
Okay. Yeah. Are you concurrent enrollment or are you out? You're still
I'm a
concurrent?
senior. So
Okay. What a strange senior year.
I know it's kind of sucky.
Yeah, but you're at school some.
Yeah. Only Thursdays.
Okay. Oh, right, because you don't have that many classes to take
Yeah.
there.
I'm only taking film photography, which when I signed up for before COVID seemed like a great idea. But now, if we have to shut down again, there's no way for me to do anything. Like, I don't have a dark room. I don't have the chemicals.
Oh, right, because you're actually processing. Well, maybe they just shifted to digital photography.
Maybe, I don't know. But it's
Okay.
been fun.
Okay. Cool. Good. Well, this, it's funny. This is the one class where I'm like, I don't even have to. It's funny because I'm like, oh, I don't have to worry. Like, we're online. It doesn't matter. My other classes, I keep being like, well, okay, what are we going to do if things shift? But we're almost done. So I'm like starting to sleep through the night, which is exciting. Okay. Well, this might be the crew today. So, chapter 46 is an interesting one for a couple different reasons. So I've taught this out of a few different books now, and this one handles it, I would say, very differently. And a lot of that probably just has to do with like the perspective of the textbook author. But to me, like the big thing from this chapter really should be shock. Like I want to make sure we've got like shock down, like we understand. And there's a lot there. So I kind of find it really strange that they actually started out with the, I can't even remember the acronyms. What was it? Systemic inflammatory reaction syndrome?
Yeah, pretty much response. Systemic
response.
Yeah.
One more time. What's SIR stand for?
Systemic inflammatory response syndrome.
Okay. So like they came in from like this SIRS, and even just watching the Davis Advantage, you're like SIRS, CARS, ARDS, DIC, like all this stuff, right? And so I think for me, I want to start with shock. So like we'll just lay that out, make sure it's making as much sense as possible, and then from my perspective, those other ones, they're absolutely related. And I think what these authors are doing is saying, hey, these things lead to shock. These things lead to shock. And I'm going to turn it around and be like, here's shock. And then we can talk about some of those things that are leading to shock. Did anyone recognize, though, anything in this chapter from our current state of affairs? From the current global pandemic?
So does COVID cause systemic shock?
It can. How does it get there?
It's like, is it your immune system overreacting. It's like a cytokine storm.
Yeah, so there's a lot going on. I guess I should clarify that, right? There's a lot going on with SARS, but basically the people who are getting really sick with SARS are developing acute respiratory distress syndrome. So when you read about ARDS, acute respiratory distress syndrome, some of that you might be like, oh, they're putting patients on ventilators. Oh, they need oxygen. Oh, hypoxemia, like things that definitely we see SARS-CoV-2 causing, right? And then as we've learned more about this SARS-CoV-2, they start talking about how it's affecting the cardiovascular system. People are getting all these clots. It's clogging up dialysis machines, right? And so then you think about DIC, right? Disseminated intravascular coagulation. Why are people getting clots throughout their body, right? So there's all this abnormal cardiovascular stuff that it's triggering as well. So, and then of course, as Chelsea mentioned, the immune system is kind of going haywire. So there's a lot going on, but as you're reading this chapter, pay special attention to ARDS, acute respiratory distress syndrome, because if you kind of get that down, you're like, oh, this is where COVID really starts getting people. So we can talk about that a little bit, but okay, let me pull up. Maybe. Here it comes. So I was like, I can't believe that there's only 4 of us. But now someone else is trying to get in and I can't see them. Where would I find them? Here comes George. Okay. Is it showing? That's showing weird, isn't it? That happened last time, didn't it? It must be something about, so when I teach Bio 111, I'm still on campus and then I come home and it's like the computer still thinks it has 2 screens. Let's try again. Okay, that's what I was going for. So if we start out with shock, this is a flow chart from my previous textbook where I said they really kind of focus on shock and then they start bringing in some of these other situations. So before we we'll dive into this chart, but big picture, right? All these different kinds of shock, right? Because there's cardiogenic shock and anaphylactic shock and neurogenic shock, right? They just kept talking about all these different forms of shock. What is shock? Let's put a definition on that and we'll go from there. How should we define shock?
Hypoperfusion.
Okay. Hypoperfusion, right? It's basically a failure to adequately perfuse tissues and organs. And what do we mean by perfusion?
Supply nutrients.
Okay, supply nutrients and oxygen, right? So blood flow. So that's a great term there, George. Hypoperfusion, not enough perfusion, not enough blood flow, right? And so, okay. So what ends up happening due to that hypoperfusion? So you can work your way in circles around this graph. And I think that's one of the hardest things about shock, right? Is thinking through all of these different ways this can go. But it basically all starts over here at this decrease in tissue perfusion, right? That is going to be shock. And so we'll go through this, but again, what we end up seeing is basically a widespread impairment of cellular metabolism. So we'll talk a bit about what's going on at this cellular level, right? And then eventually, even though we maybe are going to go through this whole cascade of different events, right? Because of that impaired cellular metabolism, what happens to those organs that aren't getting perfused?
They start to die.
They start to die, right? So again, in your chapter, they start going into multiple organ dysfunction syndrome, MODS, another acronym. I'm like, holy acronyms, MODS. Those organs start to fail. They start to die, right? The tissues are undergoing necrosis. And if you remember from anatomy, most of these organs were kind of important. And so as those organs start to fail, your patient dies, right? And they, again, your book goes through kind of an excruciating detail, like when this many organs have failed, you're at this risk of death. And oh, but wait, if it's the kidneys, it's even a higher rate of death, right? And so nothing good can come from these organs failing. And so what we're gonna see really is that untreated, right, shock is going to overwhelm your body's attempts to fix the problem, right? The problem is this decrease in tissue perfusion. And we will see that the body tries to fix that, but unless the body has some kind of help from outside, right? This downward spiral, right? This is like a positive feedback chain of events. This is going to overwhelm the body's ability to compensate for it, and so we hit this downward spiral, and very often, right, shock can be lethal. Okay, let's. Again, before I go into the nitty gritty here, I shouldn't even have brought this picture up. Here, we'll go back to this fun one. Maybe. Shock. Okay. What are our different kinds of shock? Who knows the name of one of them, and then we'll go from there.
Anaphylactic shock.
Okay, anaphylactic shock. And what's going on in anaphylactic shock?
It's the overreaction of the immune system to something that's not really harmful.
Okay, so it's an immune system overreaction, right? This is an allergy. We talked about allergies, right? So IgE mediated immune system, it becomes this systemic body-wide reaction. And how does that lead to hypoperfusion of our tissues?
Because it causes widespread vasodilation
Good.
And increased bronchoconstriction.
Good, yeah. And so this vasodilation, so some people group this as like a vascular form of shock, where your blood vessels get so much bigger that your body is basically convinced that it has really low blood volume. And you have low blood pressure. It's going to be really hard to get this blood to organs, because the whole, the analogy I used in anatomy, making a video the other day, which was terrible when I was talking about vasoconstriction, I was like, vasoconstriction, it's like Spanx, right? Just like hold it all in there. And so when you have anaphylactic shock, right, it's like you took the Spanx off and everything is just kind of like hanging out, right? So that blood pressure is going to drop when you have this just body-wide vasodilation. Let's go with, can we think of any other examples of like a vascular shock? So other things maybe that cause a very similar vasodilation situation, but from a different source.
Neurogenic shock?
Yes, good. So in neurogenic shock, right, you have something happening, whether it's injury, whether it's anesthesia, right, something like that, that's affecting the nervous system. And remember, it's the nervous system that decides vasodilation, vasoconstriction, right? So if it does something like altering the smooth muscle tone in the blood vessels, particularly causing them to dilate, that would be neurogenic shock. And again, so I said altered smooth muscle tone, like if you're thinking about the two branches of the nervous system, sympathetic and parasympathetic, who's doing what here, do you think? If we're causing vasodilation.
The parasympathetic.
Okay, so you're either increasing parasympathetic innervation to cause vasodilation or
Impairing the sympathetic.
good, decreasing the sympathetic nervous system. So you're losing that vascular tone. Good. Questions on that one? That's one I don't feel like we hear about a whole lot.
Is it typically like a trauma related shock?
Yeah, I think that's
More often?
Yeah, like actual like central nervous system problems, even like brainstem injuries. If you think about all the ways that all the different, actually that brainstem injury could lead to lots of different forms of shock. But yeah, it's often trauma related. But there is the ability of certain drugs, particularly anesthesia, to cause this as well.
So it can increase parasympathetic?
Yep, or decrease the sympathetic nervous system.
Okay.
Yep.
Why would it increase parasympathetic?
It depends on the injury that you have. Yep.
Oh, okay.
Or the drug that's involved there. Yep.
Would this being caused by anesthesia be like a mistake on like the anesthesiologist, or could it be like something already going on that it just...
Ooh, that's a good question, Bella. I don't know if I know the answer to that one. I would say absolutely an anesthesiologist making a mistake could lead to neurogenic shock. But I don't know that it's always their fault, right? Maybe some people are more susceptible to this than others, right? Ooh, that's interesting. Percent-wise, I wouldn't know exactly where that falls out. Yeah, good question. Anesthesiologists carry a lot of insurance. Like it is actually putting people, we think of it as just kind of commonplace, but putting people under for surgeries is actually a really dangerous part of the surgery. So, yep. Okay, one more type of vascular shock. What's going to cause more systemic vasodilation?
Is it the hypovolemic?
No.
Shock?
So that'll actually be like a low volume of blood rather than like true vasodilation.
Septic?
Yeah, septic.
Septic shock, good. Lydia, what's happening in septic shock, or what's causing that?
Like toxins
Mm-hmm.
from microbes.
Good. Yeah. So in sepsis, we're talking about like a system-wide infection, often bacteria, but your book does point out, right, it could be viral, fungal, etc. But most of the time we think about this as bacteria that's entered circulation, it's spread throughout the body. And so then whether they're releasing toxins or the immune system is after them, this is going to be triggering, again, vasodilation.
Is it vasodilation?
Say again?
Is it always vasodilation?
Yep. Yep.
Okay.
So we're going to get vasodilation and leaky blood vessels as a result of this. So all three of these you could, right, again, all of this depends on like how you're grouping it. So a lot of people kind of group these together as vascular forms of shock. Plenty of times you'll see them just talked about on their own. And what we're going to see is that really, does this end up being that much different than hypovolemic shock? Not at all, right? This is all going to end up kind of in the same place. So Chelsea, you mentioned hypovolemic shock. What's going on there?
Is that just whenever you lose a lot of blood?
Okay. Okay, so someone who's bleeding a lot, whether that's external or internal, right? That's dropping the volume of their blood. That could lead to hypovolemic shock. How else could we get there?
Dehydration?
Yeah, you could, it would be hard, but you actually can get there through dehydration. You could get there through excessive vomiting or diarrhea.
Like internal bleeding?
It could be internal or external bleeding. Yep, that hemorrhage. Yeah, so yeah, dehydration, whether it's from vomiting, right? Vomiting is essentially going to lead to dehydration. Diarrhea would lead to dehydration. But yeah, even, yeah, you can have enough sweating, right, that you lose blood volume. They also mention burns, right? This is a big problem actually in burns. When you have a big area of skin that's been compromised, you're not going to lose whole blood, right? But you're losing that plasma portion through the burn. And so that can lead to hypovolemic shock. Okay, who do we have left here? Oh, yep. Who we got left here?
Cardiogenic.
Cardiogenic shock, good. We can talk about each of these a little more. I just want to make sure that we have a baseline of what we're talking about here. So in cardiogenic shock, how are we running into hypoperfusion? Cardio.
Because the heart and blood vessels aren't performing how they're supposed to?
Yeah, so it's in the cardiovascular system, and primarily we're thinking about the heart here, right? So it's unable to produce enough blood pressure, right? And we were seeing this in things like heart failure. Right, and so again, heart failure is the classic. Right, so when we were talking about left-sided heart failure and right-sided heart failure, we talked about backwards effects, but then forward effects, right, were the failure to perfuse organs. So particularly for like left ventricular failure, you're not perfusing, right, the brain or the myocardium or the liver or the kidneys or all that kind of thing, right? And so we're looking at a problem there of not being able to perfuse these important tissues. I think I've got all of them now. Sometimes you'll hear people talk about just like traumatic shock, but that's often like a hypovolemic shock, right, from loss of blood, or potentially thinking about septic shock if, you know, some kind of microbe got in there as well. So I'll leave that out for now. I think these will be the kinds of shock that we'll talk more about. Okay, let's go back to the crazy graph unless we have any questions on these guys. Okay. Okay, so here's our crazy graph. Okay, and we said shock is really this issue of decreased tissue perfusion. Okay, and so they're showing you there's a lot going on here, right? Notice that decreased tissue perfusion, and this is right, particularly showing the origin of this maybe coming, they're showing it from a decreased circulatory volume, right? So some kind of like a hypovolemic shock, but it doesn't matter. Any of these shocks are going to be tissue perfusion, right? And as that tissue perfusion decreases, we're always going to run into this impaired cellular metabolism, right? And we see that really falls under these two categories: impaired oxygen use and impaired glucose use. So let's look at oxygen first, right? And this makes a lot of sense, right? The blood was supposed to be bringing oxygen, and it was supposed to be bringing nutrients, okay? So as soon as we're losing this perfusion, the cells don't have the oxygen they need, and things are going to go downhill here, right? And again, Cardiogenic shock, the cardiac output is too low to deliver it. Hypovolemic shock, right? We don't have enough fluid in the vessels to get it there, and on and on. But what we're gonna see is this very classic shift in how we make ATP, right? Because cells want to use oxygen. That's the whole point of oxygen, is to do cellular respiration. And so what we're gonna see is this shift to anaerobic metabolism. What do we know about anaerobic metabolism?
It doesn't.
Way less ATP made.
Okay, Lydia said less ATP made. Bella, where were you going?
The same place.
Oh, okay. Okay, so we don't need oxygen, which is a plus here, right? We've got an option, but way less ATP made, right? And so that's what they're showing you over here. See, if I had my whiteboard, I would just be like listing this out, but this is good. We got a flow chart. That's why I pulled this. I actually really liked this image, right? So then, and how much less ATP?
Like 34.
Yeah, something like that, right? We only get 2 ATP out of anaerobic metabolism, out of doing fermentation. So let's follow this thought, and then we'll come back and look at the other problem, right, with doing anaerobic metabolism, is that we're going to run into a lot of lactic acid. So we'll come back to that. Let's follow this thought about what happens to a cell when it doesn't have as much ATP. Now, this is really strange, but one of the biggest problems we run into as a cell runs out of ATP is that we can't run the sodium-potassium pumps. Okay, remember, this is something like 30% of your calories are going to running these sodium-potassium pumps. They were in charge of maintaining like electrochemical gradients for us, right? So do anybody recall which way the sodium-potassium pump works? Like what it's put in where?
It's the sodium's pumped inside and the K's pumped out, right?
Other way.
Is it the other way?
Yep, so we're putting things, so the way I think about it, because this forever, I was like, wait, what? Is we're putting things back where we want them. So we want more potassium inside of the cell, and we want more sodium outside of the cell. And sodium keeps leaking in, and potassium keeps leaking out, and the pump goes against that. So we bring the potassium in, and we kick the sodium out. Okay, so we put things back kind of where we want them. And that's important, particularly in systems like the nervous system and the musculoskeletal muscle, right? Is having those, both the chemical gradients correct and also those electrical gradients correct. Okay, so when this fails, notice what happens. That sodium is leaking into the cell. We've been kicking it out of the cell. And now that sodium is able to leak in the cell with nothing to pump it out. What follows sodium?
Water.
Water, okay? And so here we see, as we pull that water out of circulation and into cells, we can make our shock worse, right? Because that might further decrease circulatory volume. Okay. And now our cells are swelling, which, what was that, chapter 2, where we talked about this hydropic swelling of cells as one of the ways that cells are injured, right? This isn't a good thing. We don't have cell walls. If we get enough cellular edema, eventually our cells are going to explode and die. Right? And so kind of down here, then they're pointing out, all right, as those cells maybe are lysing, we're dumping enzymes out. Notice here they're pointing out with that decreased circulatory volume, that's a way that we trigger things like the clotting cascade, inflammatory response, etc. Okay. Okay. And that's all because we switched to anaerobic metabolism, right? We didn't have enough ATP to keep the bilge pumps running. Okay, the other half of this then is when we switch to anaerobic metabolism, we increase lactate production. Lactate's another way to say what molecule?
Lactic acid.
Lactic acid, exactly. So, I mean, if you talk to a chemist, they can tell you exactly how they're different, but for us, they're the same thing, right? So if you see lactate, think lactic acid. If you see citrate, think citric acid. If you see, okay, I'm out of examples, but right, lactate is lactic acid. And so our problem here, right, is that we actually start to develop metabolic acidosis. So how do I say this? So metabolic acidosis isn't great, right? But we might be able to compensate for that a little while, right? So if you do things like increase your respiratory rate, right, we could maybe blow off some of that hydrogen, and we could let the cells do this anaerobic metabolism, you know, for a little while. So we can compensate for that, at least some, okay? But notice what ends up happening here, okay? Again, that lower pH, remember on our oxygen hemoglobin dissociation curve, right? That lower pH is one of the things that actually tells hemoglobin to let go of oxygen. It decreases the affinity it tells it to deliver. Well, now throughout our body, right, if we have this low pH, we decrease oxygen's affinity, and hey, that just reinforces, man, we have to do anaerobic metabolism. We're not, what blood we are carrying to this tissue isn't carrying enough oxygen. Oh boy. Do you see how this is a positive feedback loop? Like these things are like feeding into each other and making things worse. Okay, so questions on this impaired oxygen use and how that's affecting kind of this cellular metabolism. Is this table starting to make sense, or is it still just a little like, oh wait, what? Okay, actually, since we're here, I have 3 things pointed out in my notes, right, about this impaired oxygen use. 3 different positive feedback loops that we end up kind of seeing on here. So things like that clotting cascade being activated, right? And again, this is just due to like the less blood, it's not flowing as well. Remember when we talked about things like how we form, you know, thrombi in vessels, right? It's that stasis. And so this is going to be one of those problems. As that clotting cascade gets activated, we might see things like disseminated intravascular coagulation, right? DIC, which we can talk about more, right? Or even, okay, I'll go there. Another positive feedback kind of in this oxygen loop, again, I pointed maybe to this one, this decrease in circulatory volume as the fluids are moving into the cells, right? That further kind of magnifies this decrease in perfusion, right? Because we have less plasma, less blood available. And remember, venous return plays a big role in cardiac output. So as you have less blood flow going back to the heart as it's working its way into cells, you decrease cardiac output, right? So even further, worse perfusion. And then this release of lysosomal enzymes, again, is kind of this end result of this impaired metabolism, is going to damage neighboring cells, right? And so we impair cell metabolism of their neighbors as well. So we kind of extend the area that isn't working very well and starts into the inflammatory response, right? So it's bad news when cells don't have enough oxygen. Okay. The other side of things, right, if this decreased tissue perfusion leads to impaired cellular metabolism, I'm gonna switch up colors just to make this exciting. Impaired glucose use, right? So we're not getting the fuel that we were expecting, right? And it's, again, because we have impaired delivery, right? There's not enough blood, there's not enough perfusion going on here. So as the cells aren't using the glucose, we see a few things happen, right? That glucose starts to build up in the blood, right? So we will very often see a hyperglycemia. And do they feed back on this too? I was going to say that also happens, like they're pointing out here. So what are catecholamines? I remember what that group is or who fits in there. So that's epi and norepi, right? So think about like fight or flight response, right? What your adrenal medulla is releasing. So you got things like, right, in this stressful response, you have things like epi, norepi, right? Cortisol, there's another stress hormone that we think of. We also see this growth hormone release. All of these end up leading to insulin resistance, which means that even if the cells are getting the hormone insulin coming to them, they start ignoring it, right? So they're just kind of like, I got other things to worry about right now. So I would add, in my mind, I'm adding another arrow here, right? The release of these guys is actually leading to more serum glucose because the cells aren't taking it in. Okay. So again, we're either getting this kind of impaired delivery of glucose or we're altering the uptake through some of these hormones or even like certain toxins and stuff, say released in a septic shock, could lead to some of these problems with glucose metabolism. So the catecholamines, the cortisol, the growth hormone are making things worse, but they were trying to help, right? Their release is actually part of our attempt to compensate for shock, right? So what these hormones are trying to do is say, oh, you don't have enough glucose to use. Why don't we feed these cells lipids instead, right? Or the cells might say, okay, wait, you don't have enough glucose, right? Let's go ahead and make some glucose. So places like the liver are trying to make glucose out of, amino acids, right? Or the liver can also do things like break down its glycogen supply, right? All ways, those hormones are just like, whoa, cells, you're not using glucose, you need some glucose. But if you think about it, like in a lot of ways that can make things worse because gluconeogenesis makes more glucose, right? And glycogenolysis makes more glucose. But if the cell is unable to take them in, right, it might actually just lead to more hyperglycemia. Okay, maybe the only real useful thing here is shifting that fuel source over to lipids.
Is this just like collateral damage? Because it doesn't make any sense that these would do that.
Yep. Well, it doesn't make sense in this particular framework, but this is exactly what those hormones are meant for. It is like fight or flight response, right? We need glucose, right? And so they're doing things, signaling things like gluconeogenesis, glycogenolysis in a normal physiology aspect. But because the cell is already doing this abnormal metabolism, you're right, it's not helping at all here.
But why would it at the same time inhibit insulin? Like, is that just an unfortunate thing it does?
Yes, and let me see if I can remember. Like why the cell. Oh, I can't put that together in my mind right now, Lydia.
If it was like one of them inhibited and the other one didn't, it would kind of make sense, I guess. So they accidentally happen at the same time, but for them to do this counteractive productions, it just doesn't really.
I've got it. So those hormones are meant to have, when we talk about them in physiology, we talk about them having a glucose sparing effect, Who are we saving the glucose for? Yeah, for the brain. And so we're telling the rest of the cells, hey, why don't you go ahead and use lipids? Why don't you go ahead and use proteins? Why, right? And so physiologically they have this role, and now it's just not applied well. I don't know if that helps at all. A little bit of an answer there. So the cells are kind of having to shift their fuel source here, right? And the glycogen might get them somewhere, right? Though they're pointing out that eventually depletes energy stores. And we really only have 2 tissues that store glycogen. Who stores glycogen?
The liver?
The liver is one.
Adipose tissue?
Nope, that's pretty much all triglycerides. Why do athletes carb load the night before an event?
The pancreas?
No.
Wait, did you say organs or just tissues in general?
Okay, tell me what you're thinking with tissue.
I don't want to say it now.
There's 4 of us. Athletes.
Say it.
Don't leave George hanging out here. He just hung out like 3 wrong answers.
I'll keep going. I got all kinds of wrong answers.
Put him out of his misery, Lydia. I'm totally kidding, George. I appreciate you.
No, it's true.
Well, I was gonna say like muscle tissue, but
yes, skeletal muscle.
See?
Skeletal muscle's an organ, Lydia, right? Think about all the like nerves and arteries and veins and connective tissue, and it's an organ. Yes. So really, the liver is the only place you store glycogen that you could actually release it to the bloodstream again. Skeletal muscle keeps its glycogen store for itself. So they're shifting that fuel source, right, if they're not being able to bring glucose in. So skeletal muscle and the liver might be able to get by for a little while, right, on that stored glycogen. The lipid supply in your body tends to be really good. So your body can kind of compensate for this impaired glucose use, right? And we can use lipids for a while. My notes say 10 hours, and I have no idea why that's the cutoff, because, I mean, you feel like you have lipids forever. It probably has to do with some of the different enzymes and things that you need to liberate those lipids. And then if you're trying to do gluconeogenesis, right, and maybe take amino acids and stuff, you start depleting those proteins from other important organs, right? And so things go downhill there. So this impaired glucose use is going to be, problematic. Check this out. So if you're trying to do gluconeogenesis, right, you're trying to use proteins to make these sugars, check out this is actually who you use first. Albumin from your blood supply. What's the major role of albumin?
To pull water into the vasculature.
Yeah, so that colloid osmotic pressure, right? Bring the fluids in. So holy cow, I kind of want to add an arrow in here, right? If you start decreasing serum albumin, boom, right? You're losing that ability to draw water in, right? And on and on. So I would say I tend to think of like this impaired oxygen use as the more immediate threat. This impaired glucose use, we do have some ways to buy ourselves some time here. But then there's also fun things like as you're breaking down amino acids to use as a fuel source, you start producing more waste products, right? Things like urea and ammonia. And who needs to get rid of them?
Your kidneys.
The kidney. And how do they get to the kidney?
The blood.
Through the blood, which wasn't like perfusing very well, right? And so like these toxins start building up in the bloodstream, right? And then I want this arrow to go this way. We impair cellular metabolism, right? Because we have all these wastes building up. This is shock. Okay. Questions on this craziness? Dude, this one's funny. So here again, we're doing gluconeogenesis. So we're trying to use an amino acid. So they're picking this specific amino acid, alanine. When you take the nitrogen group off, it looks just like pyruvate. And so the cells are like, sweet, I've got some pyruvate. But if you still don't have oxygen, you're just, right? Like you can't, you're just making more lactic acid. So anyway, bad news bears. And this presentation is posted up on Canvas. It probably still says 47. I have changed it like 5 times. It somehow keeps reverting to 47 because that's the chapter it was in the old version. So anyway, if it says shock, you're probably in the right place. Okay. So again, I pulled this one out of a different textbook just because like your book had like this very linear kind of look at shock and was just, and it does a nice job maybe of pointing out where some things go very badly, but I don't think it did a good job of kind of pointing out how interrelated all of this is and kind of all these feedback loops and how things just, they're spiraling downward out of control. Okay. So honestly, to me, if you take nothing else away from this chapter other than like that understanding of what shock is, I think you're doing good, right? You're way further. That to me is more important, right, than memorizing. I shouldn't even say this because you do know. The easier part is being like, cardiogenic shock, that's the heart failing to perfuse, right? Or anaphylactic shock, that's an allergic reaction. But we'll go through some of these details in each of those types of shock, but really it's that big overall picture of what shock is that truly is important. Okay, so let's talk a little bit. Whoa, sorry, that's my computer. Let's talk a little bit about specifics on each of those types of shock. So this one is showing specifically cardiogenic shock, right? And again, this is basically due to heart failure. This is why I thought, right, chapter 46 is shock, and I pulled it forward to come right after the cardiovascular system, right? Because it really is an issue, right, of the cardiovascular system. I think they put it at the very end because they're like, and this leads to death. I'm like, well, everything we're talking about in this book leads to death, right? So in cardiogenic shock, right, this is really due to heart failure. So notice this is starting out, let's see, where's my little box tool here? Oh, but now that's blocking this. I can't see it. Hopefully I just circled decreased cardiac output, right? This is heart failure. So whether it's myocardial infarction, or we just have a ventricle failing, maybe it was a pulmonary embolism and that was right ventricular failure, which eventually led to left ventricular failure, right? It's heart failure, okay? This is cardiogenic shock is notoriously unresponsive to treatment, right? So again, don't memorize all these numbers, but they're talking about the mortality rates with cardiogenic shock, like in the hospital, it's like 50 to 80% of these people are going to die. Like it's hard to come back out of this. And part of that reason is because when you have this problem going from the heart, everything the body does to try to fix the lack of perfusion is just making the heart work harder, right? And the heart was already failing. So this one's just rough. So notice, okay, we have decreased cardiac output and the body's like, ooh, I can fix this, right? What are 2 ways that we can fix this decreased output? Well, we said, oh, well, maybe we just had low blood volume. Let's kick off that renin-angiotensin-aldosterone system, right? That'll fix our blood problem here, right? We'll hold on to sodium, we'll hold on to water, and that will increase our blood volume, right? And hopefully we fix everything. Good thinking, right? Except, so let's look at, I guess the easiest way to do this is maybe both at the same time. Let's do both at the same time. Okay, the other way you could try to fix this is, again, catecholamine release. So epi, norepi, right? Fight or flight. Let's do some vasoconstriction. That's how we can up her blood pressure, right? The cardiac output wasn't doing enough. Let's put the Spanx on, right? And get this blood where it needs to go. And so we increase systemic vascular resistance. We've done vasoconstriction, right? So if you'd rather say vasoconstriction there, that would work. Okay, and that helps us some, right? So those two things are going to increase blood volume. It is going to increase this vascular resistance, and so we increase preload, right? We're increasing the amount of blood returning to the heart. Okay, we're giving the heart a chance to actually pump enough blood, right? Have the right stroke volume, right? Epi, norepi will do that as well. They increase the contractility of the heart and the heart rate. And we're like, okay, we got this. But as soon as you do that, right, think of all of this as putting the work on the heart. Like, hey, heart, you're screwing it up. I need more cardiac output. Work harder. Man, the heart's like, okay, I can do this. The heart needs more oxygen. Okay. I don't want to say this. Again, this is kind of like one of these downward spirals where the heart wasn't doing well. You've told it to work harder. The heart's like, okay, I'll try, but I need more oxygen. And it's not doing a good job of giving itself oxygen, right? Your book even points out, hey, remember those coronary arteries are coming right off of the aorta, right? We're trying to feed the heart first. But if we don't have enough cardiac output, even the heart itself isn't getting enough oxygen, right? And so we go right back to where we were. The cardiac output is going to continue to fall. Okay, we tried. We go back to having low blood pressure, low tissue perfusion, ischemia, and on and on and on, right? And again, what they're trying to point out here is as that heart, the muscle, the cardiac muscle itself is running into our first flow chart of all that impaired cellular metabolism, and it's not working, we're going to fall further off, right? The cardiac output is going to continue to decline. We just can't get the work done. Okay, and so that's what makes this one so hard. Okay. Yep, so big picture, again, we try to use RAS, we try to use epinephrine to fix this, but we're actually making the workload harder on a already failing heart.
So when would you say this is just, when does it get classified as cardiogenic shock and not just heart failure?
I would say when you hit here, right? So heart failure is going to trigger, right? These things trigger in heart failure, but when they fail to fix the problem, right, then we hit this positive feedback loop. And that's probably where I would call it shock, right? Because up here we just have a decrease in cardiac output, but it's really, right, it's shock when tissues aren't getting perfused. So as soon as we realize that our compensation reactions aren't going to cut it, and we're stuck in this kind of downward spiral. Does that help? Or heck, shock is always a decrease in tissue perfusion, right? So you could even think about it there. As long as these can overcome, we're not in shock yet, but as soon as those compensation techniques fail. George?
So is there, is there like a systolic threshold?
Yes.
Where once you drop below?
What is that systolic threshold?
Well, it's always 90 millimeters of mercury.
You got it, right? So 120 over 80 is normal. 90 is where you'd consider it that the heart isn't pumping hard enough to perfuse. Good.
So would it be kind of, I don't like to use the word safe to assume, but for lack of a better term, safe to assume that if your patient has a systolic blood pressure below 90, that shock or cardiogenic shock should start coming to mind.
Yep.
Okay.
Absolutely. Yep. And there's a couple different ways to do that. Obviously, like a blood pressure cuff, you lose certain pulses once you've gotten below 90, and I don't remember exactly which ones you've got there. So that would be another thing to look for. Yeah. So Lydia, I think George just answered your question. I'd say, yeah, if you're dropping below 90 on systolic blood pressure, then you're not just in heart failure, but you're in cardiogenic shock. Your book does make a good point too. You do have to be careful if someone's hypertensive. So, right, like if a normal person is 120/80, when their systolic blood pressure hits 90, you're like, oh, okay, this is someone going into cardiogenic shock. But if someone's blood pressure, I'm making things up now, if someone's normally at 170/100, that's crazy, right? They could actually be in cardiogenic shock well above 90 because their heart isn't meeting their needs. They're so used to that hypertensive state. And I think your book says if they drop like 50 below their normal systolic, that it could still be cardiogenic shock. Good.
It says 40 here, or drops lower than 40. Yeah.
Thank you. Okay, that's close. Thank you. And then again, what you have to think about is once you're in this cardiogenic shock, oh, I can't switch screens. Still can't switch screens. You're in shock, right? So everything starts going downhill, right? So the edema starts, you're dropping blood volumes, you're slowing down urine output. We'll talk about kidney, how kidney failure fits in here, and on, okay? So when they're showing this kind of downward spiral on the heart, but the rest of the body is involved as well, right? Kidneys aren't getting perfused, the liver's not getting perfused once we're here, okay? Hypovolemic shock. Okay, so we've lost blood volume for some reason, right? And I think we pointed out the big reason there is often hemorrhage, right? But again, this could be plasma, something like a burn. You could, we did say what? Sweating could lead to dehydration, vomiting could lead to dehydration, diarrhea, etc. Right? So you've lost blood volume. They're saying intravascular volume. That's just blood volume. Okay, and so they're saying, hey, due to that decreased blood volume, we're losing cardiac output, right? Because remember, the venous return, the preload, often helps determine, right, what that stroke volume is, and do we have enough cardiac output. So again, things can kind of go a couple different ways here with that decreased cardiac output, right? Of course, we try to compensate. So here's that catecholamine release, epi, norepi, right? Trying to up the heart rate to make up for that, or to increase the stroke volume to make up for that. I'm sorry, systemic vascular resistance, right? Vasoconstriction. Whew, sorry. Okay, and then we also do kind of the same thing here, right? Aldosterone is the end result of that RAS system. We say, hey, we should really increase our blood volume, right? Or recall maybe from A&P that any of those fluids inside of cells, right, or between cells, those could get pulled back, right, into the blood, particularly if it's like a dehydration form. That blood colloid osmotic pressure should have increased, and we should be drawing fluids back out of the tissues, right? Hey, we can increase blood volume. Or the spleen was our kind of storage area for excess blood. So again, these are all ways we're trying to compensate. If we can just up blood volume, right, or up the heart rate, we can fix our cardiac output and everybody will be happy with us, right? So that's our goal there, is to increase the cardiac output and fix things. And how many times has your body fixed this for you, right? You had some stomach bug and you were puking for 24 hours. You didn't die due to that loss of volume. Your body fixed it, okay? But it becomes shock when you can know, right? So remember in the video they talked, what did they call it? Like initial progressive, sorry, I have this written down. Too many acronyms in this one. Sorry, initial, progressive, and irreversible. If you've taken like a wilderness first responder course or something, you may have heard it called like compensatory shock, decompensatory shock, right? Like you can compensate, you can fix things for a while, right? It's when it shifts into that like, hey, we can't overcome this, that's problematic, okay? So that's what they're showing here, right? If we lose more fluids, you puke more, you bleed more, right? Whatever, you've decreased that cardiac output and you can't recover from it, right? You've pulled all the fluids that you can, and here you are, decreased tissue perfusion. We can go back to that first chart again, right? Because we've impaired some cellular metabolism and you are in shock. Okay, this one's not near as lethal, right? So if you think about like a traumatic hemorrhage, right? Someone cuts an arm off in an unfortunate sawmill disaster, incident. It's something they're saying 10 to 30% mortality, right? On acute hemorrhagic shock. Because what do? What can we do for this person?
And stop bleeding and increase their fluids.
There you go. You stop the bleed and you up that blood volume for them, right? Their body tried to compensate, right, to increase this volume, and it can't keep up. So you're going to do it for them, right? You're giving them IV fluids, you're giving them blood transfusions, that sort of thing. And you're right. As long as you can stop the bleeding, you can get there. Okay. And again, your book goes into a lot of details on like exactly which fluids to use, and doctors argue. Anyway, if you have the big picture, we're doing great. Okay. Okay, so if someone walks in with their arm cut off, that one's kind of obvious, right? But what about someone who, like, I don't know, was running Mary Ann runs 100-miler, right? How are we going to know if she's going into hypovolemic shock? Maybe she's been sweating too much, right? And she's dehydrated. How do we know? Like, what are we looking for? You're at let's do it this way. You're not even at the hospital. You're at the Leadville 100. It's the middle of the night. How are we going to tell if someone's in trouble?
She's going to have a increased respiratory rate and increased pulse.
Okay, so yeah, so something like an increased heart rate, right? She's trying to overcome, but she's running, which makes that difficult, right? Because your heart rate's going to be increased, but that's good. Absolutely, heart rate.
Like pale skin, or what do they call it? Mottled, like pale skin.
Uh-huh. Yeah,
because it's not getting perfused, because all the perfusion's being shunted to the abdominal organ, or the core. The core, thank
organs. You. Yeah, totally. Yeah, so you might look for like cool, clammy skin, stuff like that. There's a classic, how do I want to say this? So to try to avoid people going into hypovolemic shock in something like the Leadville 100, they actually weigh them. So as they get to checkpoints, they have to know their weight, right? Are they replacing their fluids adequately? And then it also helps them make sure they're not just like holding on to fluids, because you could hyponatremia and stuff like that. But one of the big things you'll see is oliguria, which is the crazy word for what?
Decreased urine output?
Decreased urine output, right? So you're going to say, hey, when's the last time you peed? If they're not peeing, right, at some point it's because the kidney is not getting perfused, and that's a sign that we're in trouble. So anyway, some of those kind of things that you could look for. Okay, questions on hypovolemic shock?
Would they have any like conscious signs and symptoms?
Yeah, I would expect like a neurologic impairment. Yeah, for sure. Again, some of that decreased perfusion going to the brain. And then you got to decide people who are crazy enough to run 100 miles, can you really decide? Like, you were nuts to start with, right? But yes.
Wait, okay. Can you repeat the weighing thing? What are you checking for at each check?
Yeah, so they actually, they'll weigh athletes to make sure that they haven't become too dehydrated, right? Because, you're out there, it's all on the same day. So if you've lost like X percentage of your body weight, the only way you've lost that is really through fluid loss. And so that would be a way that you could watch whether they're losing so much blood volume that we're worried about them dropping into shock. You'll also see that we'll talk a little bit about renal impairment, which is one of the things that showed up, or acute kidney impairment, AKI, i.e. renal failure. So that can happen too. So sometimes in these big races, they've cut off the blood supply to the kidneys, because remember, when you're exercising, you're increasing sympathetic nervous system activation, right? Sending the blood to skeletal muscles, fight or flight. And you're decreasing that parasympathetic, right? You're actually shunting blood away from the organs to support fight or flight response. And so one of the things you do in exercise is kind of take the blood away from your kidneys. And if you do that long enough, you can put yourself into renal failure. So anyway, which can then lead to shock. Okay. I think I just have a couple more of these. I don't think I have one for each and every shock. Let's hope not. You guys are getting the picture, right, of like how this works. You attempt to compensate, and then at some point that fails. Well, that didn't work at all here. Who's this? Neurogenic shock. So here is that idea. Something's going on in the nervous system, right? And so we're hitting vasodilation. Again, this could be a lack of sympathetic nervous system or too much parasympathetic, right? But either way, we're getting into another form of vascular shock, right? With this vasodilation, okay? Which again is leading to essentially that loss of tissue perfusion, impaired cellular metabolism, and we're back to flow chart number 1.
Is hypotension directly related to would that be always like low blood pressure or low blood volume? Or can you have hypotension and not have low blood pressure?
That
makes sense.
Yep, so hypotension is always low blood pressure, but that doesn't always have to be to a loss of fluid. So it doesn't have to be low blood volume, right? It doesn't have to be hypovolemic. But notice what happened here. We had vasodilation. We didn't lose any blood volume. But now that we took the Spanx off, right, we made that container bigger, it looks like a low blood volume. So it acts the same way? Does that?
Yeah, it does. Because when we had the case study with and then it looked like the diastolic blood pressure was very low. So it was like hypotension.
Yes.
But it doesn't mean that because there was a lot of blood, right? Mm-hmm. And it wasn't pushing all the blood out.
Right. So it could be.
I got confused, but that makes a lot of sense.
Okay, cool.
Okay.
Hopefully. Okay, good. So again, often this is trauma, spinal cord trauma, brainstem trauma. It could be also like a lack of oxygen to the brain, right? So it doesn't have to be trauma. This could be drowning, say, right? A cutoff of oxygen to the brain, even a decrease in, they point out again, anesthesia, extreme stress. That's kind of crazy, right?
That'd be like an anxiety attack or something?
Yeah, I don't know if like an anxiety attack could actually put you into neurogenic shock, but like I'm just picturing full on like, I don't know, like being in Syria, there's a civil war, like you just watched 2 of your kids die. I mean, like major things, right? Like that can actually, this is hard to kind of wrap our heads around, that you could throw your brain that out of whack, that you could lose vascular tone. Yep. And you could actually go into shock. And again, if you can fix that, right? If you can catch most of these, except cardiogenic maybe, if you can catch a lot of these early, it's corrective. Yeah. And then with something like that, think about often the body's response to something that horrific could even be just to like pass out, right? And that is actually really adaptive, because that could remove you from neurogenic shock, right? If it was this extreme stress response and you pass out, right, your blood pressure and things would be able to go back to normal. And you're prone, right? You're laying down, so that helps shock as well. Okay. I meant to go through that one quickly. Okay, here's your anaphylactic shock. Right, Bella, this is the one you mentioned, right? So again, recalling that this is IgE mediated. You don't go into shock the first time you're exposed to peanuts. Why not?
You don't
Because
have
you have.
Go ahead, Lydia.
You haven't made the like antibodies or antigens? Antibodies. Antibodies to attack the antigens.
And you don't have the memory cells, right? So that first exposure, you would start to clone the lymphocytes that actually match, say, the peanut or whatever the allergen is, right? And you figure out how to make those antibodies, but by then the peanut is long gone. But then you've been sensitized, right? So that first exposure really just sensitizes you to something. The next time you come into contact, right, you could have an allergic reaction, right? So all allergies are like that, right? The first time you sniffed a cat, right, you didn't have a reaction, but next time you're around a cat, you might have this. But in this case, right, it's going to be a systemic response. So just real quick, this tends to be the one I think that most people, they like wrap their minds around this. They're like, no big deal. So what we're getting as a result, right, of that IgE is particularly, yeah, this little thing is in my way. Particularly thinking about like the histamine release. There we go. I can't draw a box around histamine, but I can underline it, right? Because remember, histamine is what causes that vasodilation and increase in capillary permeability, right? It's the inflammatory response, but now this is going to be system-wide, right? And so instead of just being enough vasodilation to make a hangnail warm as you brought more white blood cells, you lose systemic vascular resistance. All your vessels just go blah, right? And oh, hey, the capillaries became really leaky, not because we could get neutrophils to any bacteria at that hangnail, just because everything went leaky, right? And so we have this massive, this is like a fancy way to say a bunch of fluid leaks out of your vessels, right? So you might get edema. No one really cares about that right now. The big problem is your blood pressure just dropped. And here you go, Lydia, relative hypovolemia, right? We haven't actually lost fluid, but we're acting like it. So honestly, some of it's gone out into your extracellular fluid. So maybe you have dropped volume some, right? Low volume, low cardiac output, boom, low tissue perfusion. We're back to our first spreadsheet, first flow chart. Okay, so anaphylactic shock is just a system-wide vasodilation. Questions on that one? Oh, this is fun. They also point out on here bronchoconstriction. So remember that histamine actually has opposite reactions. It causes vasodilation and bronchoconstriction. Fortunately, epinephrine, right, which is, you'd use an EpiPen for this, epi causes vasoconstriction and bronchodilation, right, opens those airways back up. I will say from personal experience that bronchoconstriction doesn't always happen. So I actually had a coworker here at CMC who got stung. We were working with the bees on campus, got stung and went into anaphylactic shock. And she was talking to me. And so I was like, well, the club has an EpiPen. She's like, should I use the EpiPen? I was like, you can't just use an EpiPen. Like, you're going to go to the hospital if you do that. And she's like, okay. Right. Like, there was no difficulty breathing. And so, I totally missed it until her blood pressure dropped so low that she passed out. I was like, 911. Right. And so it's this, like, don't count on that one, I guess.
Well, what do you count on then?
Low blood pressure.
Okay, so just
It can also be really slow onset, like you don't even know it's anaphylactic shock.
Yep.
Like I've experienced it where there is bronchospasm, but it took a long time to get to that point, and it was an unknown allergy.
What do you mean by a long time? Like over a course of a couple hours, or?
No, over a course of 2 days.
Really?
Yeah, she was allergic to sunblock. To what is the name? We're on a backpacking trip. We're out in the mountains, and we like kept putting sunblock on her. We thought it was a sun reaction to the sun, and we're like, "Oh, you need more sunblock." And
she went into anaphylactic shock from sunscreen.
Yep.
Wow.
Yeah.
Okay. Huh.
But then I'm actually curious what Lydia asked. Like, what would you count on?
Yeah. So definitely the low blood pressure. Often, and honestly, very often bronchoconstriction. I just learned the hard way that that's not always there. And then often like a hives, right? So it's often showing up on their skin too, like these wheals, these swellings, which is probably what you thought was like a reaction to the sun, huh?
Yeah, and we overlooked it. So yeah, I guess you're right. The hives is a
yeah. So hives. Yep. So.
But if someone just has like a rash or hive, it doesn't necessarily mean they have anaphylactic. Okay.
Right.
But
so I mean,
the worst.
Yeah. In fairness, this coworker's like, man, I don't feel good. I feel really weird. You know, like I set her down. We actually like laid her down and put her feet up, right, to increase, improve her perfusion of her brain, because clearly her blood pressure had dropped that much. We called her husband. He was going to come take her, to the doctor, but when we went to stand her up to go to the car, she just passed out, right? Because like her blood volume was too low. So she wasn't normal. She wasn't like, I'm fine. Like she was clearly having problems. And I should have picked up on that more. Yeah. I did give her a Benadryl in my defense. I started there. It's the first step. She now has an EpiPen, and I know to stab her. She also did desensitization shots, which is really interesting with the anaphylaxis. So you guys have heard about this, right? To like get rid of allergies, you can get shots. So it's kind of crazy, right? Because it's IgE mediated. And so what they do is they give you like really low doses of the allergen, and you're trying to stimulate, I can't remember if it's IgG or IgM. You're trying to get a different class of antibodies to find the allergen, because if they can latch onto the allergen and get it out of circulation, then the IgE doesn't find it, and then you don't get this anaphylactic response. So, and they kind of slowly up the dose, which is kind of interesting. Okay. Sepsis. There's a lot going on here, so we'll narrow this one down, right? But septic shock, they point out, is a big problem. Often gram-negative bacteria, right? Remember gram-negatives, and I only say remember because I think I had all of you in micro. This lipopolysaccharide in gram-negatives, that LPS, right? That's an endotoxin. It's embedded in the bacteria. So that's often probably most commonly the reason for septic shock, though they are pointing out here, obviously you can have gram-positive organisms, it can be a fungal infection, right? But what is bacteremia? I can't circle it for you. What does that mean?
We got bacteria in the bloodstream.
You got it. So bacteria in the bloodstream. All right, that's kind of kicking all this off. It's okay if you have bacteria in a knee replacement, right? It's okay. I mean, it's not great, but it's okay if you have bacteria because you have strep throat, but you don't really want it in your bloodstream, right? That's when things go downhill. So that bacteria or those toxins in the bloodstream are kicking off this inflammatory response, right? And so really, it's coming down to inflammation. And what we'll see, let's see where they get into this. So things like nitric oxide, right? Nitric oxide is a vasodilator. Oh, what else do they have on there? Do they have tumor necrosis? Tumor necrosis factor that they put up here, that's actually what's triggering this nitric oxide release, right? But nitric oxide is this vasodilator. And so what we start seeing due to all of these cytokines, right? So whether they're pro-inflammatory or anti-inflammatory, right? We have this great battle going on in the blood, and what we're going to see start happening is damage to those endothelial cells. So out of this whole center section, right, I think what I would say is like, okay, because there's bacteria in the blood, we have all these pro-inflammatory cytokines, and that makes sense, right? We're signaling inflammation. There's an infection, fine. And then we also end up trying to block some of this inflammation, right? And both of those together, right? Basically, I would say we end up at this endothelial dysfunction. So pointing out things like, hey, there's our leaky capillaries, right? That starts to look like anaphylactic shock, right? We're losing fluid. We could decrease our blood volume there, but it gets worse, right? So we get all these thrombi forming, right? So blood clotting taking place. Things are totally out of whack here. Impaired vascular tone. Remember, the endothelium is the one who makes those first changes, right? Different chemicals being released from the endothelium, things like nitric oxide. So again, vasodilation is going to be a big problem here. And so all of those, right, are going to lead towards tissue hypoxia. And then they're pointing out MODS, right? So things kind of start going downhill. Once you hit tissue hypoxia, you're thinking about shock, right? And again, this is systemic, because if you have bacteria or toxins in the bloodstream, it's going throughout the body. Okay, so you're going to lose blood pressure, systemic vascular resistance, and again, things like these thrombi, you start being concerned with disseminated intravascular coagulation, and then they're pointing out here multiple organ dysfunction. Septic shock is definitely a problem. Was that an understatement? Septic shock, I was like reading my notes at the same time. Septic shock, this is a big problem, right? You do not want bacteria in your bloodstream, and it goes downhill from there. Okay.
This can be like residential bacteria, right?
It can. So they, where did they point? They pointed out
like in the
that,
gut?
Yeah, so in some of these other times, maybe when you've decreased gut perfusion, so you could be in a different form of shock, and then as the gut isn't getting perfused, and it becomes leaky, and bacteria get out of there, and then you could, yeah, exactly. Good, and that was totally the right response, Lydia, too. It's like, oh no, yeah, this goes badly. Okay, but again, here's your big picture, right? Come back to this. Decreased perfusion, impaired cellular metabolism, and it goes downhill from there. Sorry, I didn't give you a break, and we're almost out of time already. Okay, so let's sorry, I talked way too much. And now I don't know what to do except keep talking, because I do want to make sure, yeah, I do want to make sure that we're okay on some of those complications. So things like ARDS, disseminated intravascular coagulation, kidney failure. So I'm just going to keep talking, but you guys are going to help me out, please. So kind of complications of shock. And again, at the beginning, I said your book kind of came into shock from all of these, and I'm kind of going the other way. I'm talking about shock and then thinking of these things as complications, but it can kind of go both ways. So ARDS stands for what?
Adult respiratory distress syndrome.
Adult respiratory distress syndrome. Told you there were too many acronyms. I keep calling it acute respiratory distress syndrome. Adult respiratory distress syndrome.
It says acute in the book, but everywhere else it says adult. Like Davis Advantage, it says adult.
Oh, sweet. Okay, so I'm not like totally off my rocker. Let's just do this. Let's ride the fence there. Okay, so this respiratory distress syndrome, right? They talk about the key thing to get here is what they're calling refractory hypoxemia. What does that mean? What's hypoxemia?
No oxygen.
Okay, so we're not getting oxygen. Basically what this comes down to is you are not getting oxygen across the respiratory membrane, and this refractory portion is just meaning it doesn't matter what you do, right? You put someone on 100% O2, you're not improving their O2 stats, right? Like oxygen is not getting across, oxygen is not getting absorbed. That was supposed to be no, there we go. And I mentioned this is one of the things that we're actually seeing here in SARS. So really any time you have kind of this pulmonary edema, that can thicken the respiratory membrane, right, and make it harder for oxygen to get across. Often that, that fluid, that exudate, it's often immune mediated. So this is one of those times where your immune system can actually make things worse, right? So you have this viral infection in your lungs, right, SARS, and now as the immune system goes in and is all like guns a-blazing, right, it's actually causing enough inflammation that you're getting the fluid in the lungs that's actually making it so you can't absorb oxygen, right? So this isn't all the virus's fault. A lot of times this is the immune system. Often in ARDS, you'll also see, so remember we have type 1 and type 2 pneumocytes. They do different things. Both of them are getting damaged. Type 1 is where you get gas exchange. What do type 2 pneumocytes do?
Are those the ones that like produce surfactant?
It is, yep. So as they get damaged and you lose surfactant, you can actually get alveoli collapsing. Alveoli that are collapsed, you are not getting oxygen diffusion to your blood. Right? And so this is one, right, they're talking about, okay, often these people are put on ventilators, right? And your book even goes into ECMO, which is crazy, but it totally makes sense. If you're truly in this refractory hypoxemia, a ventilator doesn't help you, right? The ventilator is just like helping your lungs work and you've got someone on oxygen, but if you can't get that oxygen across the respiratory membrane, that doesn't help you. Did you guys pick up on what ECMO was? And now, again, the freaking abbreviations, extracorporeal, like, so outside the body, mechanical, I'm making this up, mechanical oxygenation. You can look it up later. ECMO, And it's basically a lung outside of your body, right? They're taking the blood out of your body, running it through an artificial lung and putting it back in you. That's how messed up your lungs are, right? In ARDS. Okay, disseminated intravascular coagulation. Holy cow, what does that string of big words mean? Disseminated.
Widespread.
Thank you. Everywhere, right? Like widespread. Intravascular, so inside of the blood vessels, clotting is taking place. So clots are forming inside blood vessels all over the body, right? Abnormal clot formation, particularly in the microcirculation. So we're seeing this, you know, down in arterioles or capillaries that we're getting this clotting taking place. Clots, of course, obstruct that blood vessel. So we end up with ischemia and those tissues get damaged. So then the really weird thing in DIC is you get all these clots, right? You've got thrombi forming all over the place. Okay, but that uses up a bunch of platelets and a bunch of coagulation factors. And so then you start bleeding, right? So you kind of have this like back and forth, right? It's not just clotting everywhere. You get a bunch of clotting and then you've used up the clotting factors. And so then maybe like that surgical incision or whatever just starts bleeding, right? Because it can't hold a clot. So this is obviously problematic, right? The thrombi lead to obstruction, which leads to ischemia. And then depending on where that ischemia is, we have problems, right? If that's in the kidneys, ooh, we can go there next. Acute kidney injury, right? That sort of thing. So you're damaging the tissue that's downstream of those clots. So again, counterintuitively, on that DIC, you might actually have to give someone clotting factors, right? Because if you just did surgery on them, you don't want them bleeding, right? And so as they're going through this, you may actually have to give them, say, plasma that has clotting factors in it because they're using theirs up. Super weird, super weird. I will say, your book did a nice job of pointing out, this is going down in the ICU, right? A lot of this stuff is going to be ICU kind of things. They purposely put this in the same chapter with death, all of this. So acute kidney injury. Other sources will call it acute renal failure. Okay. So one of the main ways you can get this is in shock, right? Because the kidneys are hypoperfused. As the kidney isn't getting enough of a blood supply, right? And heck, you could probably get this from DIC as well, right? If that thrombus is in glomeruli, right? The capillaries in the kidneys, right? You could start clotting that stuff up. Anyway, shock is one of the main ways you'll see this. But as that kidney is getting hypoperfused, some of the cells in the kidney are dying, right? And you're losing your ability to now filter the blood, get rid of wastes, right? And so you'll see some of those waste products start to build up in the blood. In particular, things like blood urea nitrogen levels, right? Those nitrogenous wastes the kidney was supposed to get rid of. Creatinine is another kind of breakdown of proteins. Big thing to look for here is that oliguria, the low urine output. If you are less than 400, I can do a little gator there, less than 400 mils per day, basically that's a really strong indication that you don't have enough blood supply to the kidney, right? It's being hypoperfused. So someone who's in the ICU is going to have a catheter in, and you're actually measuring urine output, right, to make sure that their kidney doesn't lose function. Because this is often hard to come back from. If the kidney's not working, what does your patient need?
Dialysis.
Dialysis, right? Try to do that filtering for them. Again, you're in the ICU. They don't need extra waste products in their bloodstream. They have other problems going on. One of the big problems that they've started talking about with COVID, right, is they're actually, right, so we're saying COVID is causing ARDS, right? They're getting this pneumonia, they're getting this fluid in their lungs, that's leading to this refractory hypoxemia. We're trying to put them on ventilators, etc. They're also finding basically disseminated intravascular coagulation. They're getting blood clots all over the place, okay? And then a lot of them, things are going downhill. They're getting put on dialysis, and those clots are actually blocking the dialysis equipment. I mean, this is like, it's a junk show going down with this particular illness. Anyway, okay, last but not least, MODS. Again, I have zero clue why none of my notes have these acronyms. Multiple organ dysfunction syndrome. Yeah, did I get it, Bella? Thank you. Okay. So again, you could have, there are multiple reasons, right, why you could end up in this multiple organ dysfunction situation. Your book points out that systemic inflammatory response syndrome, SIRS, can start shutting down organs. Shock absolutely can shut down organs, particularly septic shock can move in on this pretty quickly, right? But even, you know, anaphylactic shock, the liver, the kidneys only go on so long without being perfused, right? Any of these shocks, this is the problem. This is what kills you. Shock leading to multiple organ dysfunction. If 2 organs basically shut down, they say you've got a 50% mortality rate, right? If 5 organs shut down, you have a 100% mortality rate, right? So thinking about trying not to get to this point. And I think that's a really, maybe the key thing to take away from this shock chapter is treat this stuff early, right? Go after it quickly, because if you can prevent someone from going into shock, that's way easier than getting them out of this downward spiral, and way, way easier than getting them out of multiple organ dysfunction, right? So for what it's worth. Holy cow. Okay. 2 o'clock, that was chapter 46. Sorry, I talked the whole time. I actually had like things for you to do. Okay. Questions? Okay, hopefully that helps some. I know it's kind of the opposite direction that your book talked about it, for better or worse. So, okay, so I did make an announcement. There was a second Davis Advantage, but it wasn't showing up on your Davis Advantage. I didn't have a right due date on it. So take it I changed the due date to today, but take it at some point. I won't mark it as wrong, but it does talk more about kind of those ARDS and MODS and stuff like that. So go ahead and take it. It was a good video. And all that, so. Okay. I will also point out, so we've got, I believe you get your next exam next week. So kind of keep that one on the radar. And I will say, after the next exam, I do not have Canvas up to date. So I will be working on that this weekend. But if you've been watching Canvas and you're like, oh, there's like nothing due the rest of the semester. No. I'm just like barely afloat, so I'll work on it. Okay? Okay, take care, guys.
Thank you.
I have a question, Becky.
Yeah.